In this video, let's discuss about the treatment of hyperkalemia. So, our major concern in a patient with hyperkalemia is the risk of arrhythmias. So, our treatment focus starts there itself. We give the patient IV calcium gluconate to stabilize their cardiac membrane and to prevent arrhythmias. Remember 10-10-10 rule here. It means 10% of calcium gluconate, 10 ml of it has to be given over 10 minutes. You have to give it slowly at the IV site to prevent any irritations and extravasations and thrombophlebitis. Its onset of action takes 1 to 3 minutes and its duration lasts for 30 to 60 minutes. Remember to repeat the ECG after 10 to 15 minutes and check for persistent hyperkalemic changes in the ECG. If the changes persist, then you have to repeat the second dose of calcium gluconate. Like that, you can repeat up to 4 doses in 1 hour. But if the patient's hyperkalemic changes still persist, then you can have a nephrology referral. So this is how we briefly stabilize the patient's cardiac membrane and prevents arrhythmias. So coming to the next step in the management, here our goal is to decrease hyperkalemia. So you can decrease the potassium levels by 2 ways. One is you can cause intracellular movement of potassium into the cell, intracellular shift of potassium into the cell, or you can cause excretion of the potassium. So to cause the intracellular shift into the cell, we can be giving insulin bolus, or you can give them albuterol nebulization. Albuterol is a beta agonist and it also causes potassium shift into the cell. Similarly, insulin has the same action. So one thing we have to remember is, if you're giving insulin and you have to check the patient blood glucose level. If the blood glucose level is less than 250, you have to give insulin in dextrose to prevent the patient landing up in hypoglycemia. And the nebulization, albuterol nebulizations, regarding that you have to remember that the doses we'll be using to cause intracellular shift into the cell of the potassium are higher than what we typically use for asthma. Here we use around 5 to 10 mg in 10 ml of NS and then we give nebulizations. So that's how you decrease the potassium levels by movement of potassium into the cell. So what are the other mechanism? The other mechanism I was mentioning is the excretion. So you can give potassium binding resins. So they bind to the free potassium and they excrete it. But it cannot be used in acute conditions. It can be used if it's a chronic CKD patients and they'll be having elevated potassium. In those kind of patients, you can be using potassium binding resins, but in acute conditions it's not much of use. And also remember to give cautiously in patients with constipation or paralytic ileus, because its mechanism is excretion, and if that is not working proper, constipation and paralytic ileus is there, it wouldn't be so helpful. So other way of excretion is you can induce diuresis. So in which patients can you induce diuresis? So you have to see if the patient's urine output is adequate, and also if the patient is having normal fluid status, good volume status, then you can give furosemide and induce diuresis. In that way the potassium will be excreted. So these are all the conservative measures to decrease the potassium levels. Even after using all these conservative measures and the patient's potassium level is not decreased, then you can do dialysis, refer to nephrology, also do dialysis in the patient. In the end, remember to address the underlying causes that is causing hyperkalemia. You have to address it, you have to treat the underlying causes. Also remember to avoid any nephrotoxic drugs like NSAIDs. Any nephrotoxic drugs, if the patient is using, try to avoid them. Also during the hyperkalemia treatment, remember to monitor the patient's GRBS. Here you are giving insulin to correct the patient hyperkalemia. So you have to monitor the patient's GRBS. So that one you have to monitor, and you also have to monitor the patient ECG to see whether they have come back to the normal or not. And you also have to monitor patient's potassium level. So apart from the vitals and everything, you definitely have to monitor the patient's GRBS, potassium levels, and ECG. And that's a very brief about hyperkalemia treatment. I hope it helps. Thank you. Thank you so much.